Good afternoon, friends. A hearty welcome to this course titled Phaco Basics. And I am Arup Chakrabarti, the chairperson for this course. And helping me out are Dr. Sai. He will be joining us shortly because he is attending the executive committee meeting. And then we have our scientific committee chairman, Dr. Srini. I think he also will be joining us. He has been extremely busy. And Dr. Chandrakant, can you please come over to the dais? So a brief introduction of our speakers. Dr. Jacob Koshi, he will be the first speaker to go. I think you can wait there with the talk. And Dr. Jacob Koshi is a professor of ophthalmology at Believers Church Medical College and Hospital, Tiruvalla. He is also the Dean of Medical Students at the Believers. He has got more than 2 decades of surgical experience with manual SICS and Phaco. He also is a glaucoma surgeon and he has a special interest in complex anterior segment surgeries. So over to you, Dr. Jacob. So, one second. So it is actually only 7 minutes talk, and we'll have all the talks, and if time permits, we'll take up a few questions as a panel discussion, as well as questions from the house.
Good morning, everyone. I would like to thank all the people on the dais, especially Dr. Arup and Dr. Sai, for giving me this opportunity. I'm going to do a very basic talk on someone who's learning how to convert from SICS to Phaco. What are the things that you can do? Now, for all of us in the medical field, the first thing when you're trying to do something new is to try and look at the literature. Now, if you go to PubMed or even in Google and try and study about transitioning from Phaco to SICS, you will find hardly any literature, because all the literature is in the West, and they talk about transitioning from Phaco to SICS, not SICS to Phaco. So for us in India, we who learn SICS first, and you want to start doing Phaco, the first thing that you need to do is to go for wet lab training. There is no substitute to this. You can't straight away start on a human eye before doing wet lab training. Of course, make sure you're comfortable with your microscope, especially depth perception. Do not try and learn Phaco if you're not yet fully comfortable with SICS. Rexus size is important, especially doing a Rexus. Make sure that you're already doing a Rexus all the time. And in Phaco, usually the Rexus may be slightly smaller, so just keep that in mind. Now, this is a very important step that I suggest to all my juniors, and that is to get comfortable with the Phaco foot pedal. Try and do bimanual IA. You can make 2 small side ports on either side and do the IA through that. Now, that is just to get used to the Phaco foot pedal. Remember, there's a difference here. You have only 2 positions, that is irrigation and irrigation aspiration. You don't have 3 positions like you have when you're doing Phaco proper. Learn to implant foldable lenses. You can make a 2.8 millimeter side port incision and try and put foldable lenses through that to get the feel of how it will be when you're doing a Phaco emulsification. Using your non-dominant hand is very important. Try and do some writing, brushing teeth. Use your left hand when you're doing SICS surgery more. Try and do a Rexus with your left hand while doing SICS surgery. It's very interesting. It is such a positive reinforcement when you complete a Rexus with your left hand. You feel that you can start doing things better. Learning about the machine is important. Remember that you have to know about the parameters, what is being used. Preferably have someone from the company. They will give you and help you with your settings in the beginning. They can help you. You cannot use the settings of a senior surgeon when you start. Learn a bit about the Phaco tip, especially what kind of tip you want to use. It's slightly different, especially some of the Kelman tips, which are angulated quite a bit. You might end up in trouble because you're not used to that. So learn a bit about it and be conscious of that when you're starting surgery. Get additional instruments. Don't try and minimize just managing with your SICS instruments. Whatever new that you need, please buy that. Learn how to use sharp instruments, especially inserting it in the eye without damaging the wound. This is totally different from an SICS wound, which is wide open. You must learn how to get in and out without damaging the eye. Then you move to using coaxial IA. Again, if you have a 2.8 coaxial IA, make a 2.8 side port. After removing the nucleus through SICS, do your IA through the side port and learn how to use the coaxial IA. Now, what we always recommend for all PGs is to do the step-by-step training program, where you don't do the whole surgery in one go. You do a step-by-step. First thing is to watch videos, watch plenty of videos, assist a lot of cases. This is not given enough importance now. You must scrub up and assist the senior surgeon, learn how they assess problems. They will tell you how to recognize early signs and how to manage the complications. A wet lab structured program, there are so many places that organize that. This is what we do in our places where we train. We first start with IOL implantation, then making the corneal incision, then learning how to do IA, cortex removal, then doing capsular access, nucleus fragmentation after the initial crack is done, then trenching, then breaking the nucleus, and finally the whole surgery. Knowing how to do anterior vitrectomy is paramount. Please do an automated anterior vitrectomy for your complicated SICS cases. You can't start doing it in your Phaco cases. You must learn how to do it in your other SICS cases. Choose cases carefully. Don't go for the difficult deep-seated eyes, one-eyed patients, hazy corneas. This, of course, be very careful. Now, even if you're comfortable with topical anesthesia, please give blocks when you're learning a new surgery and decide on the technique you want to do. When to convert, this is to convert. When you're doing Phaco and you run into trouble, these are some of the parameters that I would look at. If you're running into any difficulty, convert back to a technique that you're comfortable with. It's more important to give the patient good vision than to say that we did the surgery in a difficult condition. I'm just going to end with one small video. For those of you who are working in settings where you don't have a senior surgeon along with you, this is how I learned 20 years ago. So I was comfortable with SICS, so I would make a temporal incision and try and do a temporal Phaco sitting at 12 o'clock. And now the reason is if I run into any trouble, I can convert to a superior SICS. Now here you can see that a trap flap has been made. It's a combined surgery, but I just took it to show my technique for Phaco emulsification. So at any point of time during the surgery, because I'm alone and I run into trouble and I want to convert back to an SICS, I can use the superior wound to convert back. Here now there is a slight difference that I do here, and you would see that my side port is almost 180 degrees away from the main port. That's because I use a supracapsular technique nowadays most of the time. This is to cut down the energy use, where you go on top with the Phaco tip and you go below the nucleus with your left hand. And so there is no initial trenching, but that's not part of this study, this talk. I'm not going to go into the details. Just learn how to, if you do this, if you run into trouble, you can't crack the nucleus, you can't do something else, just stop and convert to a superior SICS, what you're comfortable with, so that you can finish the surgery. The end of the day, remember that you can do a new surgery, but you have to work hard at it. Don't give up hope if you have a few troubles. All of us have gone through the same path. Thank you very much for your patient listening.
Thanks a lot, Dr. Jacob. It was a beautiful presentation. The next speaker is Dr. Matthew Kurian, and he will be talking to us on a very interesting as well as a complex topic: Phaco dynamics, machine settings, and customization.
Thank you, Arup. So Phaco dynamics is understanding the machine, and the forces that act on the nucleus through the machine are the jackhammer of the Phaco emulsification, irrigation, and aspiration. I have no financial interest for this presentation. So there are 5 dynamic surgical components: aspiration flow rate, vacuum and bottle height, and the ultrasound power. All put together work, and the incision size is what actually keeps these things in certain critical limits. The ultrasound power, sonics, generates the heat, and the rest of it is to cool down and prevent corneal wound burns. The first step, of course, before we start anything is priming and tuning, which often we don't do. The staff will be doing for us, but we need to understand what they do. Priming is to check the fluidics, and tuning is to check the sonics of the Phaco tip. The handpiece converts the electrical energy into mechanical energy, And today, almost exclusively, we have piezoelectric crystals in the handpiece. 4 or 6 is a current standard. The frequency, the terminology is basically the speed at which the Phaco tip moves, and it is fixed for the machine. Higher the frequency, the greater the efficiency of fragmentation, but also more the heat. The power is varied by altering the stroke length or the amplitude depending on the machine that we use. The Phaco tips are what actually deliver this mechanical energy into the eye and break the nucleus fragment into pieces. A thinner, sharper one is preferred. This will last longer, this will last shorter. The larger the opening, the easier to remove fragments. The smaller the opening, you have to spend more energy to break the nucleus into smaller pieces. Lots of angulations are available, but today I think we have come to a conclusion that approximately a 30 or a 40-degree tip would be the best. Recent advances in the tip are Ertley's Easy Tip, which is very good at maintaining the chamber stability, and the Balance Tip by Alcon, which is fantastic for nucleus emulsification. There was a thought that mechanical, cavitation and acoustic energy all work on the eye. But if we increase the power, you will see that at a certain point, small bubbles, which is the cavitation bubbles, will appear at the tip. And then as we increase the pressure inside this hyperbaric chamber, you will see that the cavitation bubbles get cancelled. So Jamie Zacharias made this award-winning video where he was able to demonstrate that with cavitation and after increasing the pressure without cavitation, the efficiency of the Phaco tip in emulsifying or embedding into the lens matter was equal. So this was actually a landmark concept because we wanted to maximize the mechanical jackhammer effect and reduce the cavitation, because cavitation is what causes the free bubbles, the free radical formation and damage to the endothelium. Power settings range from 0 to 100 in the older machines, and in today's machines we have a method of able to start from a threshold and then move to higher. And there are fairly reliable guides on how much power to use for trenching, which is slightly more, and for the nucleus emulsification it's slightly less. Panel mode is where there is continuous from the beginning of foot position 3 to the end of foot position 3, and linear control by the surgeon in more experienced individuals. You can have a control starting from the beginning with less amount of energy to high energy at the end of the foot pedal. Variations of this were required because there was it was noticed that corneal damage, etc., was more. So burst is where you have a duty cycle which is linear and the power is fixed. So as we go down in foot position 3, it tends to become continuous at 100 whatever preset level. Whereas in pulse, the duty cycle intervals are fixed, but the power increases as we go down in foot position 3. Further modulations of this were to have microburst and hyperpulse, and that is to give more effective control of energy. The irrigation part, we want to balance the infusion into the eye with the amount of aspiration and wound leak that can happen, and is governed by the bottle height. Pumps, different, peristaltic pump, vacuum pump, but actually today's machines, the difference is very minimal, and we need not really worry so much about that, other than to know that in peristaltic pumps you can independently control these two variants. Aspiration flow rate governs the followability of the piece to the eye, while the vacuum is the holdability of the piece, and the rise time is the time taken for the system to reach the preset vacuum. This is surge is one of the most important concepts. The IOP rises when the fragment is occluding the flow, and then when there is a sudden release, you have a drop and chamber collapse can happen, and this is when complications occur. The modifications that we can do is surgically to reduce outflow and increase inflow, but machine specific, the balance tip from Alcon, the bypass system, AMO fusion fluidics, cruise control, the easy tip and speed technologies are all variations to make it better and safer for the surgeon. Thank you.
So good afternoon, friends. It was a very nice talk by Matthew. It is actually covered a lot of ground in a very short period of time. So use this as a stepping stone for reading up this topic, because if you don't understand phaco-dynamics, fluidics well, it will make it difficult for you to negotiate the phaco learning curve. So my topic is capsulorhexis pearls. We know it is the most influential step in cataract surgery, in phaco surgery, and it is also the most challenging situation, particularly in the initial stages of a learning curve. And most of the complications happen that time. And actually, we can talk about phaco pearls. It can go on for about 1 or 2 hour course. But what I have decided in my presentation today is I'll just show you a few typical case scenarios. And if you happen to negotiate, you happen to encounter them in your during your phacoemulsification, it will be useful for you. So before I show you the videos, a little bit about the sizing. We all know that the rhexis size should be 5 to 5.5 millimeter, and you need to keep a 0.25 to 0.75 millimeter overlap of the anterior capsule for various reasons. I'm not going to that. But if you happen to encounter a small rhexis, here for example here, it may not be safe for you to continue with phacoemulsification, particularly if I'm dealing with a soft cataract or if I'm dealing with a very hard cataract. I need greater access into the lens matter, so I need a greater window, opening of the anterior capsule. So in this particular case, I decided that, I need to have a larger rhexis size. So I used the same cystitome to create a nick on the rhexis margin and then enlarged it. So this process can be done with a microrhexis scissors, and then you can use microrhexis forceps from the main incision or from the side port. Most of the time I use the cystitome in case if it is not an intumescent cataract. Then of course you need to have a proper grasp and proper purchase on the capsular flap. So cystitome did not work out fully here. So I had to re-inject OVD into the anterior chamber, took the ureter forceps, and then grabbed the anterior capsular pedicle and made a larger rhexis. So this is something which you need to do if you are dealing with a very soft rhexis. So this is the rhexis, if you are dealing with a small rhexis, the rhexis was completed. And this is after the secondary rhexis, and things went off pretty well. Now, this is another case. This was a very shallow anterior chamber. Patient had raised intraocular pressure, and it is an intumescent cataract. Now, when I did the rhexis, I was scared that I was not able to form the AC, and I was scared the rhexis may run to the periphery. All right, and these are the cases where we tend to make a little smallish rhexis, because if things are happening in the periphery, untoward things, then it is very difficult to salvage it, bring it back. So I made a smallish rhexis to be on the safer side. Now I need to make a larger opening here. Eye was extremely hard. So if I inject OVD into the eye, a cohesive OVD into the eye becomes very hard, and there is always a possibility of the uveal tissue prolapsing through the paracentesis tract or the main incision. So what I did in this case, and I needed to have a larger opening, larger rhexis, about 5.5 to 6 millimeters. So I just decided that I will not take the other recourse to the other options like passband vitrectomy to soften the eye, because it was a total cataract. I would not have seen the phaco tip what it was doing. So I used my phaco handpiece and did central phacoemulsification of the exposed area of the nucleus, and then went little behind the capsule. So now I have the rhexis, which is actually located in a deeper aspect of the anterior chamber, and you inject OVD, the intraocular pressure really doesn't go up, and you have a deep anterior chamber, not much of stress on the anterior capsule, and continue with the rhexis. So this one, if I had not employed this technique, then I would have, all these patients had received IV mannitol to soften the eye pre-op, but nothing had worked out well. So here, it does pretty well, and I get a decent rhexis for a safe phacoemulsification that you see here. Now, this was actually, from time to time, I encounter this problem, particularly when the rhexis margin approaches the inferonasal area. So that is the area where particularly people with big, peaked noses, deep set eyes and drape reflexes. So here, if you see here, at one point, I have perforated the capsule once again and initiated a fresh rhexis. And then there is a capsular tag. So sometimes it may be very minute, you may miss it. But in this case, I knew that things were not very safe because visibility was compromised. So I injected OVD and then took that particular tag and converted into a rhexis. So at each and every stage of your phacoemulsification, whatever step you do, you must be very, very critical and scrutinize the findings and take corrective measures so that there's no cascading effect down the line and surgery goes on smoothly. So this is how I avoided this mishap. Now this was another scenario which happens from time to time, particularly when I was a younger surgeon. I mean, I have completed about 3 decades as a phaco surgeon on 20th October. So here, this is peripheral margin of the flap is the active margin. This is where the capsule is being torn. But if you see the inner margin of the capsular flap, so that is something which in this kind of cataract, you don't expect any problem. But if the force dynamics are not properly employed, the inner margin, it is not an intumescent cataract. It doesn't have an inherent tendency to run to the periphery. But the inner margin may, it may go towards the outer margin of the rhexis, developing rhexis flap, capsular flap. And if they meet together, then you have a very odd shaped rhexis. So this is the way to overcome it. I may put the whole capsular, the 2 lobules, upside down, and then and treated these 2 aspects, 2 different units as one single unit, and turned it around. And if I had done that, I would have got a very small odd-shaped rhexis, and again I have to go in with micro-rhexis scissors and forceps, and things would have become a little more complicated. There are certain situations we just cannot do anything about rhexis extension. Like this was a very young patient, silicone oil filled into the anterior chamber, into the posterior segment, very, very tense cataract, and it went out to the periphery. But I feel that if you have begun your rhexis well, and if it tends to go to the periphery, it is an iatrogenic tear. It is something which could have been avoided. And now we have a couple of, so the technique which we have been following, for donkey's ears, if it is a intumescent cataract, you make a small primary rhexis and then debulk the capsular bag. The primary rhexis should not be too small. If it is 2 millimeters or less, sometimes when you debulk with your irrigation aspiration, you may stretch the rhexis margin. And trypan blue stain rhexis margins are quite friable, quite rigid. I think Minu had done a very nice study which won a lot of awards on the effect of trypan blue on the capsular rigidity. So it may tear. So it is about 3 to 3.5 millimeter is ideal. If you try to make it bigger, the primary rhexis, it will run to the periphery and then you cannot get it back. So this is the standard technique I think most of us employ. And now here, for example, I'm showing you some of these unexpected problems. This is a fairly routine cases for most of us Indian cataract surgeons. Primary rhexis goes on pretty well. There's no issue. And then when I'm trying to enlarge the primary rhexis by giving a capsular nick, so let me check here. Here, okay, so now I'm taking the Vanna scissors. I could have used the micro-rhexis scissors. So with the Vanna scissors, if you see here, the scissors doesn't cut, it's like a forceps. It cuts and then, if you see here, it draws the capsular flap and after cutting it, it draws it behind. So then I have just punched a defect in the anterior capsule. So it is a continuous thing. However much you pull it, you're not going to get a tear. There is no angularity in the capsular opening. So again, you have to make a fresh cut proximal to where the rhexis margin had ended, and then subsequently you do a 2-stage rhexis, and then it is, easy peasy. There's no problem, and it went off pretty well. Now this was another case where this shows the classical Little maneuver. This is a technique which Brian Little has described. We have done many courses together at various international meetings. So here, the primary rhexis goes on pretty well. There's leakage of fluid, the water cleft and vacuoles that is happening. So that is to be expected. But if you see the paracentesis here, it is pretty long. The inferior paracentesis, it is pretty long. And here, the relevance will be clear to you a little while from now, a little later from now. Now, when I cut this anterior capsule here, again I'm using the Varna scissors. So here it cut it and then it pulled it back. So you have a rhexis, a capsular flap which goes almost to the periphery. So it is important to inject the cohesive OVD not at the center but at the peripheral to where the potential rhexis tear might happen. So here I created a fresh paracentesis because it was, I think, a little deep set eye and then the corneal tract was pretty long. So if you try to manipulate the capsule from the existing paracentesis incision, there will be a lot of overlocking, corneal stria, visibility will be, will be impaired and there will be jerky movement. So please watch what exactly the little technique is about. Now I am pulling it. So a fresh paracentesis incision is created just to get the rhexis straight. And then using the rhexis forceps, you grab it very close to where the rhexis, close to the V, where the tendency was there to run off to the periphery. Again, it punches it here, but then again here, I'm pulling the rhexis in the opposite direction. So the intended direction of rhexis is this, but I'm now pulling it in the 180 degrees away. So once you see that rhexis has started coming under control, you bring it to the center and then pull it radially. And like any other, rhexis, capsular microrhexis, used capsular rhexis. So again, this is an odd hourglass shape rhexis that had happened. And so we used a Varna scissors. This time I took the microrhexis scissors and then the forceps, and then it went up pretty well. So little technique is something that we need to be really familiar with. So basically, if you have a swollen lens, I would prefer to use IV mannitol. In some of these patients, I'm talking about patients where the lens is swollen, the AC is extremely shallow. And then at times I have done a past-line vitrectomy to open up to make the eye a little softer. And then OVD strategy, again, I use a very good quality cohesive OVD for rhexis. Rhexis I initiated, I use the cystitome and then use a two-step technique as I've told you earlier. And then one stage rhexis. So basically, since the time is over, so in summary, so stain the capsule whenever visibility is low, even if it is not in mature cataract. Pre-op IV mannitol in selected cases. You may aspirate a little bit of cortex with a needle before you start the main rhexis. Always attempt a smaller initial rhexis, two-stage rhexis in intumescent cataract. Maintain the anterior chamber depth with cohesive OVD. Be ready to work from the side ports. Use appropriate instruments. Thank you very much for your kind attention. And before I wind up, can I have the last slide? I think that was before that. This one, yeah. So I just requested help for my onward journey in All India Ophthalmic Society. I'm contesting for the post of Vice President, online elections. Please cast your vote and support me. Thank you so much. So I think Sai has come. Yeah, Sai is here. So next speaker is our outgoing president, Dr. Sai Kumar. And he doesn't require any introduction. He's an excellent speaker, a fantastic surgeon. And he's going to talk on incisions and hydroprocedures. Over to you, Sai.
Thank you. I'm sorry for being a bit late because the executive committee meeting is going on. So I'll finish the talk and go, and maybe one or two questions, if with the permission of the chair, we can take. So basically, this is a talk on Phaco basics, so I'm going to stick to just the basics, nothing, no fancy stuff. So I'm going to talk about the paracentesis, the main wound, and the hydro procedures. So just a few pertinent points about the paracentesis and the main wound. We are all presuming that we are going to do the Phaco from a temporal location. Although there are many of us, when we started Phaco, we started with superior, then shifted to temporal. But I think the general trend now is that you have a temporal location. If you are a right-handed surgeon, your right paracentesis will be somewhere around 6 o'clock, and your left paracentesis will be slightly closer towards you. Again, the location of the paracentesis is not a sacrosanct rule. You can have it according to your convenience. There are surgeons who have it very close to the main wound. There are surgeons who have it slightly away from the main wound. There are also surgeons who don't use a right paracentesis at all. So you have the main wound and the left paracentesis alone, and the rhexis is done through the main wound. And for the Phaco, you only need one, but I generally do 2 paracentesis. What is the blade that you want to use for the paracentesis? You have 2 options. You have either a straight blade or an angled MVR. and the length and breadth of the wound is very, very important. Okay, so we'll just play a very, very short video. So this is a straight 15-degree blade that is being used. Always stabilize the globe when you're doing your paracentesis. Especially when you're doing your initial cases, you can either, if you are under a peribulbar block in your learning curve, you can use a tooth forceps. Otherwise, you can use a small bud to stabilize the globe while you're doing it. And in topical phaco also, make sure the patient is, not moving inadvertently while you're doing this important step with the sharp instruments. So once your paracentesis are done, then you go at the main wound. I would advise you to have a blade which has got a marking. Many of the blades are available with markings now. This marking is about 2.5 millimeters from the tip of the blade. So that will give you, if you are making a 2.4 or a 2.2 incision, it will give you something like a square incision, which is very, very stable as far as the cataract surgery is concerned, and the sealing of the wound is very important. So this is the angled MVR. I use the angled MVRs mostly in all my topical cases and also in sunken eyes. When you are using the side entry in a very sunken eye, you find it difficult to use a straight one, and then you can use an angled MVR in such cases. So this is again, you have an opening of about 1.5 millimeters, and the angulation should be sufficient enough. Here again, you can see that the marked blade is being used for the main wound here. So what are the wound related issues you are likely to have? You can have either a long or a short paracentesis. Short paracentesis do leak. You can have a bit of iris prolapse if the breadth is more, and especially if you are doing a case of IFIS, you can have the iris coming on into the wound quite often. If it's, if the breadth is too much, you can have wound leak during phaco. You can have shallowing, because each time you move your second instrument, you can have a shallowing of the chamber. If it is a very long wound, you can have what is called overlocking. You might find it difficult to put in your instruments. Your maneuverability inside the chamber comes down. And if it's a very tight wound, especially nowadays, if you overfill the chamber with some of the newer OVDs, you find it, you see that the phaco tip gets blocked, and there can be a bit of wound burn also. So just a few pertinent points about hydrodissection. The word itself is called cortical cleaving hydrodissection. So you can use either a normal cannula, the rounded cannula which we use for our air injection, or a trypan with the same cannula can be used, or you can also have a beveled cannula, which is slightly easier to place it under the capsular axis. Do it at multiple points, definitely 2 if necessary more. Always inject small amounts of fluid. Don't inject too much of fluid and increase the pressure in behind the nucleus. And always decompress every wave of fluid you make. Even though you have seen the wave come out through the other end, always decompress the center of the nucleus so that you don't let the pressure build up behind. If you have too much pressure behind, you can have what is called a capsule blowout. It can occur commonly in a posterior polar cataract, but if you have a very small rhexis and you inject too much of fluid, especially in hard cataracts, you can still get a blowout in other situations as well. Do not use too much heavy OVDs in the chamber. I prefer HPMC during my hydrodissection. You always depress the lip of the main wound so that don't let too much pressure build up inside the chamber. So this is again a short video clipping of hydrodissection. This is a beveled cannula that I am using. You can go under, you can see that the wave is seen, and then you go to the other side and then again decompress. This is the normal rounded cannula. This also can be used for your hydrodissection. Again, at 2 points the hydrodissection is being done and the center is depressed. There are some special situations of hydrodissection. The first one is hydrodissection in posterior polar cataracts. You can actually do a PPC without doing a hydrodissection at all, but in case you want, you can do a very, very minimal hydro, I would call it a hydro procedure. It is not even a hydro delineation, just loosening up the anterior epinucleus there, and then without rotation you can make the trench there, and you can slowly rotate the nucleus into your phaco tip and do a good phaco emulsification. This is again a case of a hydro delineation, again a posterior polar cataract. You may not get an exact golden ring in every case, But if you can find that right plane, maybe in the second or third attempt, you will see that you are cleaving that nuclear part from the rest of the epinucleus. Again, two situations where I advise you not to do a hydrodissection. You have these very hard brown cataracts with lot of thick epinuclear intumescence around it. We do a double rhexis in these sort of situations. After the first rhexis itself, you are sort of decompressing and using either a bimanual or a Simcoe cannula to decompress. And in these situations, you don't need to hydrodissect. And again, you don't need to hydrodissect in Morgagnian cataracts, where you immediately, as you do, you can see the lot of leaking fluid from there. And in these situations, you'll just find a small nucleus inside. In femto, what I do is I make a small trench in the center initially, because there is some air that is collected behind. I don't hydrodissect with the air, although many surgeons believe that it is safe. So I do a small trench there. I let out the air first and then do a very limited hydrodissection. So in summary, hydro procedures and wounds are very important. Multi-point, small fluid quantities to be used. It makes cortical aspiration very easy. If you've done a good hydrodissection, your cortex aspiration is very easy. You should know when not to hydrodissect at all, and you should also do a very careful denilation in select cases. Thank you very much for your kind attention. One or two questions, if you want, I can take, or else I will. Anyway.
Thank you very much, Dr. Sai. We'll move on to the next speaker, Dr. Prabhu Shankar, who will be talking about nucleus management best suited for you.
Regarding the management of nucleus in Phaco, we basically have three techniques. And okay. So either with divide and conquer technique, the stop and chop, and the direct chop. Here first I'll show the divide and conquer technique. Okay, initially what you do is create a deep trench in the center of the nucleus, almost up to the close to the rhexis margin. And once you feel that depth is deep enough, then with the chopper in one hand and the Phaco probe in the other hand, you can just divide the nucleus. See there, I'm going to be making the first chop there. This is basically divide and conquer technique, which most of us have to learn it in the initial days. And once the first trench is over, and the second trench, either you can directly go for a stop and chop, or you can directly again do a same similar procedure in the other quadrant of the nucleus. So try to make at least 4 to 6 quadrants in each nuclear fragment, and it's very easy to emulsify. So now again I'm fragmenting one more quadrant now. So once you around 6 fragments are there, then you can start emulsifying each quadrant. So only thing you have to be careful is the settings will change. If you're going for a direct chop and stop and chop, you don't have to change your Phaco parameters. But when you're doing a divide and conquer technique, initially you want to do a deep trench. So you have to keep your vacuum around 100 and your Phaco power around 40. So you do the deep trenching, make the nucleus fragments. Once you have enough quadrants there, then you go for a setting. You can go for a vacuum around 300 or 400, then your Phaco power around 50, depends on each machine. So now the new machines, you don't need much of power. Even 40 power, you can just manage the nucleus management. So always make sure when you're fragmenting the last nucleus, where all the PCRNs occur, so make sure your tip faces the iris or towards the corneal plane. That's how you can avoid the surge when you're doing the last bit of Phaco. Next to it. Yeah. Initially, when you're doing your Phaco, make sure you have a large capsular excess around 5.5 to 6 millimeters, because the trouble starts when you do very small rexes around 4.5, where you'll end up hitting either the rexus margin, or you cause a lot of stress over the zonules and get the ZD during the Phaco emulsification. So initial days when you're starting Phaco, make sure you do a very large rexus, at least 6 millimeters, so that even in case you want to convert to a SACS, it's very easy to convert. Achhi. There's another case, same, I'm going to do the same trench, still with the second instrument either can be a dialer or a chopper. Initial days always make sure you use a dialer. So once you're pretty confident, then you can go for the chopper. So stabilize the nucleus with your left hand if you're a right hand surgeon. Then start the deep trench from one edge of the rexus margin to the other one. Always there's a confusion how deep to go. So always once your tip is already well buried, that shows that your depth is quite adequate, because always you don't know how far to trench, how deep to go. Sometimes they say that unless you get a good red reflex, you trench. Sometimes you go so deep that red reflex becomes too much, and that means you already caught the PC. So make sure your tip is buried there. And once your tip is buried, then you go for the chop. See, this is almost stop and chop technique. So once you've made the first initial divide and conquer, next fragments you can always go for the stop and chop. So each I've made it 2 semi-half nucleuses. Then each quadrant again you'll have to do multiple quadrants. So whenever there's a posterior capsular component there, sometimes your chop may not go through the center of the nucleus. So that times you'll have 2 different nucleus fragments there. So always try to remove the central core of the nucleus and then do the chopping. So here I'm using the horizontal chopper. So, but don't try to stuff the nucleus. I've seen a lot of surgeons using dialer and trying to stuff the nucleus into the Phaco tip. You don't have to do that. The machine only will do it. So all you have to do is stabilize your Phaco handpiece, and the pieces will come to you. You don't have to go and stuff the nucleus into the Phaco tip. And make sure that we're doing the last emulsification. You can see the video that my tip will face towards the next third one. So both the techniques I've just showed, both divide and conquer and stop and chop. The last video is direct chop. Playing. No, start. No, same place. Just 1 more minute. Yeah, this is the direct chop there. I think it's gone back to the old video. Okay. This is the direct chop there. So you'll have to use a sharp chopper, either 1.5 millimeters, 2 millimeters vertical chopper. So it's good for hard nucleuses. So you can initially making the first 2 big nucleus fragments, then you can chop each fragment. See, I'm using a sharp chopper and making small fragments with using the chopper. Then make sure you don't exaggerate too much force while rotating the nucleus. And that central nuclear part is the core one which needs to be removed before your remaining fragments come. So I'm just removing the central core now. Okay, just hold on please and so each make multiple fragments and remove the nucleus. Don't try to bring a big fragment. That's the one time you will tend to get a SK. And make sure when you're doing the last piece of emulsification, make sure where my probe spacing is facing the iris plane, so that in case you have a surge, you'll not hit the posterior capsule. Thank you.
Thank you, Prabhu. We'll move on to our last speaker, Dr. Minu Mathan, talking on cortical wash and IOL implantation.
Thank you, Chairman. This topic goes last. That means cortex and IOL is last. And I am given 6 minutes, which is lesser than all other talks. So don't underestimate the importance of these two, because this is, for me, this is the stage when...
Actually, mentally, a lot of us at the end of nucleus management relax and create a lot of PCRs during INA. So
Exactly. So even I also have got maximum PCRs during INA only, and most of you would also have experienced that. There is relaxation and also not taking this seriously. So no financial interest in this. So we can use a Simcoe cannula or an automated bimanual or coaxial. So Simcoe is not bad, you know. Simcoe, see the timing. So we go near the cortex, catch with a little vacuum, bring it to the center and aspirate. Just like you do in SICS, but your incision is smaller. So we can even use this also when you are transitioning or in early phases if you are scared or whatever reason. You can use Simcoe. Simcoe is not at all bad, not at all inferior to anything. It takes a maximum of 20 seconds, 25 seconds to finish off a regular cataracts cortex aspiration with a Simcoe cannula. But the problem is that many sizes of Simcoe irrigation are available. See, this kind of a flow is important. If it comes drop by drop and the irrigation is very small, each time you try to aspirate, you will get chamber shallowing. Because your incision is also not exactly fitting. It is 2.8 or 2.2, but still your Simcoe will be smaller. The other advantage is, so I buy from Indo-German. No financial interest in this, but I am just telling you what is available. That gives the maximum irrigation as far as I know. And so the going through a side port is also very useful with the Simcoe, especially when there is a subincisional cortex and a small pupil. You can access the subincisional area much better. So in Simcoe also don't consider this as a very weak instrument. It can do all harm also. So if you go to the periphery and aspirate small bits of cortex, see, I just have pulled the bag from the equator. So this also can generate enough vacuum, and be careful with your Simcoes. Moving on to automated ones, coaxial gives you the maximum irrigation, needs only one port, and again the same thing, go towards the cortex, catch with minimum vacuum, and once it is caught, move towards the center and then aspirate it. So go contiguously, one clock hour to the next clock hour, because when you aspirate, the next will be free, and your flow, the aspiration flow rate, I keep it at 30 to 40 according to your machine which you have. The vacuum is moderate. Now see what happens. I try to, see, I just caught the PC. So trying to aspirate small bits of cortex, again you will catch PC. So a bottle height or active fluidics as you have in your higher machines to maintain the chamber very well, because there is nothing in the chamber. There is no nucleus. The PC is directly facing you when the cortex is taken out. So be very careful. Should not have too much of vacuum. I keep still in a highest end machine, I keep still 400. So you can go down on vacuum, do it slowly, but the chamber should be stable. Irrigation should be enough. That is the most crucial. Here you can do a cap whack by keeping very little 10 vacuum and 10 flow and polish the PC, or you can use the hydro jetting which I showed just now to make it all fly away and prepare your chamber for your IOL implantation. So yeah, the disadvantage of this is that going subincisional, we need to turn the tip down. So then you can directly catch the PC. So when there is a small pupil and the chamber is almost empty and you have subincisional cortex left, I inflate the anterior chamber, and then you can use phenocane which is available now. If it was larger, you can dilate it on the table, and then fill the chamber, push the PC back, and then turn the tip down and immediately catch the cortex. Or what you can do is start off subincisional first. Nowadays I do all cases subincisional cortex first. When the anterior chamber is full of viscoelastic, and also when you have lot of cortex which is protecting the capsule. She is very suggestively bringing a 5-minute this one. We realize that there is 5 minutes only left, but I have 2 minutes more. So we move on to bimanual IA. See the aspiration port. I am comparing it with the coaxial. Coaxial is 0.3. So the smallest it is, the best it is, because it will have less of surge. So many companies make with wide, large aspiration ports. Don't buy. So please go and see under a microscope and see the smallest possible. It will take some time, but it will be safer for you to aspirate cortex. And here, the irrigation is always lesser than the coaxial. So buy ones which give you maximum irrigation, have the pole high up so that you get maximum irrigation. And use the incisions which are fitting for the type of IA which you have. You may have multiple types of IAs in your sets. So every time you place one incision, some will not go in, some will go and will be smaller. So see which one you have and titrate your incision so that it just fits. No overlocking, no leaking. Then you will get much better maneuverability and much better chamber maintenance. Here again the same thing. Go towards cortex, catch with a little bit of vacuum, bring it towards the center, raise the vacuum fully and aspirate, and then go towards your cortex which is adjacent to what you have aspirated. Last 1 minute. So exchange hands, you need 2 paracentesis here to aspirate the 180 degrees. The advantage is that you can reach all clock hours very easily. Very good, but you need 2 paracentesis. You need to adjust to the lower irrigation which you have. Then coming on to foldable IOL implantation, see this is one commonly used IOL which goes into this kind of cartridge. The leading haptic is folded and the optic should be flat on the floor of the cartridge. That is very important. And then push it forwards and make sure that the plunger hits at the bottom or the edge of your optic. And then if you are using a 2.2 millimeter incision, most of us do a wound assisted one. So the part of the tip goes into the incision, not fully. So you need a counter traction with the side instrument. You can notice that my side instrument is pulling it back, the globe, keeping the globe straight. And it can be delivered into the bag fully or partially and then manipulated with your second instrument. And one thing we need to avoid is to hold the lens onto the center. Do not hold the center of the optic. Hold only at the haptic optic junction because otherwise it will leave marks on the optic. And lastly, these are butterfly cartridges which commonly are available and some are loaded, preloaded. This is partially preloaded. The lens is already in there. You need to put viscoelastic. Some of them are fully closed. So you just have to push in visco from one side and then make sure that the edges of these optic and the tip are underneath these 2 side flanges, because once you close, the whole lens should be within that hollow area. Nothing should be in between the flanges. Otherwise it will get locked there and you will get a torn IOL going inside. And the leading haptic is better folded back so that it goes into the bag. And I fill always sodium hyaluronate because it forms the chamber very well and it is easily taken and completely taken out after implantation. And later on you can even use a hydro implantation also, but make sure that your chamber is always full while you inject the IOL. Thank you very much. So we have some time.
We have got 2 minutes
to
before
discuss.
the
We can
next
take
team
questions.
is ready to sterilize us. One suggestion to all the people in the audience and for us on the training side also, formally look and document the technical difficulty of each surgery in the form of a Najar's risk score or any other risk score, and formally document each step, how well you perform it, using ICO Oscar Phaco scoring. This is my suggestion. I found it very useful in my practice. With that, if nothing, 1 minute more. Any questions from the audience? Thank you then for your patience in the audience. And with 1 minute more, we will hand over to our next set of people.